Thank you so much, Parminder. I hope everybody can hear me, and I'd like to welcome everybody to today's presentation on celiac disease. Some of you are either done with your dinner, some of you are at dinner, or some of you are planning dinner. So let me just go ahead and say this as a disclosure that although gluten will form a rather hefty dose of this lecture, rest assured that after digesting this presentation, you should really have no adverse events and look forward to having some kind of decent meals after this. I have no conflict of interest to declare for this lecture. I just like to say that living to eat equals eating healthy and a healthy life. We do know that a lot of us suffer from adverse food reactions. So before starting on talking about celiac disease and gluten sensitivities, I just wanted to go over some adverse food reactions. I'm kind of, perplexed at the choice of this topic, which was don't be a gluten. We know that gluttony is overindulgence. And most of you listening to this presentation, obviously, I would think are not gluttons. It also means that we take over unpleasant tasks or unreasonable amount of work. So you are actually doing over and above what you would normally do on a good Tuesday evening. So what are adverse reactions to food? It is the abnormal physical reaction to ingested food. And it could be either due to allergies or non-allergic processes. It's interesting to know that 20% of industrialized nations, including ours, the population report adverse reactions to foods. So that means there's about 10% prevalence of food allergies in adults and children. And of the 35% of self-reported allergies, only 3.5% of these patients eventually go on to be diagnosed as food allergic after food challenges. 90% of the time, it is allergies to milk, so dairy, eggs, wheat, soy, peanuts or tree nuts, fish, and shellfish. Over time, some children do develop tolerance to milk and eggs, as well as to wheat and soy. But seafood and nuts, typically the allergies persist. So when we look at adverse food reactions, we're looking at allergic reactions and non-allergic reactions, or the non-immune mediated adverse food reactions. And what do I mean? So when you look at commonly eaten foods that cause eating angst, you have both the IgE related immune responses. So those are allergies now. And just so we know that celiac disease we're going to talk about is not an allergic reaction. It's more of an immune mediated. So it's an autoimmune disease. When you look at IgE mediated food allergies, those are the oral allergy syndromes. When somebody eats something and they have a tingling in their mouth, it could be diarrhea. Something interesting that I learned over the last year was something known as meat alpha-gall syndrome, where patients have had prior exposure to tick bites, and then they develop an allergy to meat. So within hours of eating meat in their meal, they start having diarrhea or pain in the belly, abdominal pain. Most of these allergies are food dependent, and they could be exercise-induced allergy too, or anaphylaxis. The response to these patients, usually you have a lot of different breathing issues. You can have skin allergies and skin rash. You could have tachycardia or heart beating very fast and palpitations. So these are all allergies that are to foods. Now the non-IgE, and we'll talk about celiac disease at length, but I wanted to talk about the other food reactions. It could be food poisoning, either from bacteria in preformed toxins or contamination of bacteria of foods. Occurs very much in the summer when we go out for barbecues and we're eating coleslaw that's been left outside or meat that's not been properly cooked. Then there are the metabolic disorders such as lactose intolerance, and people can develop either diarrhea, they can have gas and bloat symptoms, or they can have, just abdominal pain after drinking milk. So, the way to get around this is to have things like, oat milk or sometimes almond milk. There is also fructose intolerance, which is also common as lactose intolerances. Sometimes non-gluten wheat sensitivity can also fall into this group, where patients start having symptoms of pain, bloating of the belly, and sometimes diarrhea. There are also physiologic responses, and it goes along with patients that have heartburn or patients that might have problems with reflux. There are bacterial fermentations that occur. So if you eat beans, you can have a lot of gas and bloat symptoms. So patients that have gas and bloat after eating onions, garlic, legumes, bran fiber, or broccoli, we know that those are foods that can lead to a physiologic response, as well as heartburn from the fatty foods, chocolate, peppermint, and wine, which relaxes the lower sphincter or the lower valve, allows the stomach acid to come up into the esophagus. Then there are pharmacologic responses to food, and these are with blue or aged cheese, smoked meat, sausage, pepperoni. And then there are chemical or irritant effects, such as people start sweating or start having a lot of nasal congestion after eating spicy foods. And then there are food aversion disorders. So one of these are bulimia, but it's newly diagnosed as something known as RFID, which is an avoidant restrictive food intake disorder. People have food phobias, and in these cases there may be a psychological overlay which may be playing a role in patients having food reactions as they eat them. So how about celiac disease? Now it's interesting that if you look at how long we've been eating wheat, it's almost 10 to 20,000 years that humans have been ingesting wheat in their diet. So something about this is the adaptation or the natural selection that makes some of us start having problems with wheat and an immune reaction to the wheat. It is kind of an evolutionary paradox, but it's also unique amongst autoimmune disorders that we know what the trigger factor is. So if you look at celiac disease, it's a complex multi-system disease involving both the GI tract and the skin, but also neurology, or the nervous system, musculoskeletal systems, endocrine system, and reproductive system. We talked about it being an immune response to gluten, which is present in the wheat, as well as in some other grains like rye and barley. It's interesting that it is genetically inherited. However, when they've looked at people in, say, Punjab, India, where the inheritance of the genes is pretty much, the prevalence is constant, some people develop celiac disease, others don't. Most of the time, it is in the northern hemispheres that patients have these genes and they have the immune response to it. If you look at the prevalence, it's pretty common. It's 1 in 100, so if there are 100 people listening to this presentation, there are at least 1 or 2 that have celiac disease amongst this group today. It's more common in women. It occurs at all ages, and sometimes you see it even in the geriatric population, even though it is an inherited, genetic disease. And geographic variation, like I talked about earlier, is in the northern hemispheres. We talk about an iceberg phenomenon where a lot of these patients are not diagnosed. And in the US, it sometimes takes up to 10 years for the patient to get a final diagnosis of celiac disease. In the UK, this is almost 7 to 9 years. Patients can be asymptomatic, which means they do not give us typical symptoms, report typical symptoms, and that's part of the reason. So it does pose a diagnostic challenge to the physicians, also because of the iceberg phenomenon, as well as the wide spectrum of the clinical manifestations. And these are all the different areas that are involved, from the skin to the GI tract, to the reproductive system, to the stomach, to the joint and muscles, as well as in the mouth. You can have ulcers or tooth enamel erosions. So the classic symptoms are the gastrointestinal symptoms. And I should let you know that nowadays, more patients are diagnosed because of their atypical or non-classical symptoms, non-gastrointestinal symptoms. The classical symptoms are features of malabsorption syndrome, where you have chronic diarrhea. So it's not acute diarrhea after you've gone traveling and you've had a food poisoning, but this goes on for a while. Or fatty diarrhea, which is known as steatorrhea. Patients often have weight loss and malnutrition, and children suffer from growth failure. It's interesting to note that 20% of these patients may actually present with constipation, and 10% of the patients may actually be overweight instead of being malnourished and underweight. Also, 10% of the patients that are diagnosed after the age of 60. So as I said, it can be diagnosed in the geriatric population as well. Patients can have a short stature, failure to thrive in childhood, delayed puberty, lethargy or weakness, weight loss of more than 10%, although 10% of these patients are obese, abdominal bloating, discomfort, flatulence, a lot of flatus, nausea, heartburn, or indigestion. And rarely it may present as a life-threatening diarrheal illness or a celiac crisis, where patients have multiple electrolyte disturbances. In the long term, if this is not treated or taken care of after diagnosis, then there is a risk for intestinal cancer. The non-classic or the atypical symptoms, or you can also say they're extraintestinal symptoms, the most common one is iron deficiency anemia. Metabolic bone diseases, patients may have frequent fractures. Their liver tests may be abnormal. Patients may have skin rash like dermatitis herpetiformis, or even have eczema. They can have headache, depression, numbness, tingling, joint pain, fatigue, tiredness, cerebellar ataxia, that means imbalance, seizures, or sometimes a brain fog. Now, the caveat over here is right now we're going through the end of the pandemic, and some of these symptoms may also be related to the COVID-19 pandemic. So if patients have had this, some of these symptoms, they could be very well related to the after effect of the pandemic or the infection. And then in infertility and recurrent miscarriages, it's important to remember that patients may have a single extraintestinal symptom, or they can have just this symptom without malabsorption symptoms or the GI symptoms. So moving on to anemia. The symptoms of anemia are either due to iron, but it can also be due to folate or vitamin B12 deficiency. So when the doctor is looking at the blood results, they may see a varied form of anemia. It can occur without the GI symptoms, as I mentioned earlier. And most of the time, celiac disease is overlooked in menstruating women because they, or people that have had multiple pregnancies, because we, kind of attribute the anemia in women of childbearing age to their pregnancies or to the menstruating, cycles of their high, heavy menstruation. So we should remember to look at these patients if they have anemia, which is not correcting after having given them iron. What do I mean by premature bone disease? It could be fractures, and the risk is 2 to 3 times higher in these younger women, because we know that older patients do tend to have fractures and increased incidence of that. But when you see that in younger women or younger men, one must look at other alternative explanations, which could be from either chronic inflammation because of celiac disease or malabsorption of calcium and or vitamin D. They can also have elevated liver tests, which can be from the celiac liver, which is reaction to this, autoimmune hepatitis, or sometimes patients, the 10% patients that were overweight could be from non-alcoholic fatty liver disease. Now, coming back to the current times, during the COVID pandemic, a lot of patients did take to increased amount of alcohol ingestion. So alcoholic liver disease is something else that should also be kept in the differential diagnosis at the back of our minds. Alkaline phosphatase, which is one of the liver tests, can be elevated because of vitamin D deficiency or because of associated autoimmune diseases of the liver, such as sclerosing cholangitis or primary biliary cholangitis. So what do we do to patients that we think might have celiac disease? First and foremost, it's trying to get a detailed, comprehensive history. So when you go to the doctor, you want to write down all the possible symptoms that you have. So we know that, the doctor gets a complete profile of what's going on. We complete physical examination whilst you're there in the doctor's office. And if you're doing this over, like a virtual visit, then some of these things that we'll go over can be seen in the physical exam as we're doing a virtual visit. Obviously, we do lab tests. There's bone densitometry that's looking at bone health. And if indicated, endoscopies with biopsies, imaging studies, so x-rays if they're indicated, and referrals to your primary care may send you to the gastroenterologist, dermatologist, endocrinologist, rheumatologist, allergy immunologist. So a variety of different physicians, as well as a registered dietitian, because the patient that's going to go on the specific diet will definitely need the help of the dietitian. So in the history, we talked about classical and extraintestinal symptoms, but what else do we look for? We look for the comorbid, endocrine issues, including type 1 diabetes, thyroid, and adrenal. And I've had at least a handful of patients that are referred to me directly from the endocrinologist who was treating them for autoimmune thyroid disease or for type 1 diabetes mellitus. Also, referrals from the rheumatologist who's seeing the patients for connective tissue disease. And then the hepatobiliary disease is something that we would see. And then patients that have Down or Turner syndrome are at increased risk for celiac disease. In the family history, we are sure to ask for history of celiac disease, either in the parent or the sibling or the child, that's a first degree relative, or second degree relatives, because if the patient that comes to us has a family history, then there's an increased risk for celiac disease by almost 15%. Now, I talked about physical examination, either when you're going to the patient, to the doctor's office, or if you're doing it virtually. It's easy to determine if the patient stands up or even reports short stature, or pallor, which can be looked at by checking out the fingernails or the eyes. Dental enamel effects that could be seen by having the patient smile and showing their teeth. Stomatitis, again, the mouth. Mucosal aphthous ulcerations or chylosis, which is around the edge of the lips. Muscle wasting, loss of adipose tissue, so wasting. Bruising is easy bruising because of malabsorption. You can look and see if there's pedal edema or swelling of your feet. We can't check for postural hypertension again, unless the patient has their own blood pressure, checking at home. And then if they have history of fractures or tetany, which is when you have calcium that's very low. And then skin rash can be seen through the virtual platform. What are the currently accepted indications for lab testing then? So when we look at lab tests, there are, again, patients we talked about with the classic symptoms, the non-classic symptoms, and then we talked about the associated conditions. So all of these patients, we could test for celiac disease. Now, there's a problem with testing universally for celiac disease because even though it's common, there are the risks of diagnosis and the risks of the treatment, which is gluten-free diet, which then makes the patient at risk for other forms of deficiencies if they do not have a complete balanced diet. So right now, the American College of Gastroenterology, as well as the United States Preventive Services Task Force, that's USPSTF, suggests that there's insufficient evidence for testing people universally for celiac disease with the tests, which we'll talk about in a second. And it's okay if the patient has a first degree relative and requests this, or if we see any of these signs on either history or physical examination. It's interesting, one must check, if you're going to check a child, then you want to do it after 1 year of gluten ingestion, so after the age of 2, even if they have family history of celiac disease. So when we go to the referrals, we've talked about lab tests, the tests that we will be doing, complete blood count, looking at their electrolytes and the liver tests, their thyroid tests, celiac serologies that's specific to celiac, immunoglobulins, because if you have IgA deficiency, then your celiac serology tests may be negative. There are genetic tests, which are just once in a lifetime tests. We can check for vitamin levels, iron levels, ferritin levels, copper and zinc, bone densitometry. And as I keep alluding to, the multiple specialties that are involved with this, it does take a village to take care of these patients. So it's all of the subspecialists as well as the registered dietitian that, come into play for these patients. So I just want to go over briefly, not that you need to know any of these things, but it's interesting to know what tests your doctors are looking at. And one of the tests that's known to be very sensitive and specific is the tissue transglutaminase. We used to do the other tests before, but we know that this one, if your IgA levels are normal, then it's a pretty good test. And so it's a test of choice. The test has to be at least 3 times the upper limit of normal, because a lot of times there are minor elevations in these tests and patients think or are told that they have celiac disease. It's sometimes if the patient's been on a gluten-free diet or not eating wheat, which is bread or any of the other wheat-containing products, they may have low titers. But it's important to remember that a lot of times these tests are pretty specific. We check for IgG if the IgA levels are low, and and then if the IgA levels are low, and we check for a deamidated gliadin. You can have seronegative patients, which means the test could be negative, like I said, if you're not taking gluten. But a lot of times we then move on to the next test, which is a genetic test. Now, the good thing about the genetic test is it's a great test if it's negative. So it has a strong negative predictive value. If both the genes are negative, then you do not have celiac disease. You do this test only once in a lifetime because your genes really don't change unless you're changing your genes that you wear. But the genes that are in your blood, you do not change. There's a 30% prevalence of these genes. So if you have the genes, does not necessarily mean that you have celiac disease. Celiac disease, as I keep repeating, is a complex genetic disorder. So there is a hereditary component, but the microbiome, that is the bacteria in your system, as well as your diet, have to be there for you to develop this autoimmune celiac disease. I usually check patients for the genetic test if they've already been on a celiac-free diet and their TTG or the serology test is negative, and I have a high kind of suspicion that the patient may have celiac disease, either because of family history or because of the symptoms that they are presenting with. So the clinical indications for celiac disease, we've talked about this. I want to emphasize a gluten challenge, because if patients come to me without being, on a gluten diet or gluten in their diet, you want to challenge them gradually, because patients, if they start their, bread or something else right away, they might start having more symptoms. And the point of seeing my patients is not to make them feel worse. It's actually to make them feel better. So, you try and get them to start with 1 slice a day and then increase it. So it goes from 2 grams. And then if they're able to tolerate it, you keep doing it for 6 weeks and then come back and then do the endoscopy and do the biopsy. If you have a low pretest probability, meaning that, there are symptoms that are kind of vague, you may just do the serology. And then if that's positive, then go for the duodenal biopsies. We'll talk about that in a second. But if you have a high pretest probability, like I said, if you have family history or you have symptoms that are very typical, we go with, both the, serology as well as getting a biopsy. And if I have, symptoms with genetic testing, if there's family history. If the patient is on a gluten-free diet, there's really a very low sensitivity to this test. So when I talk about biopsies, you're really getting your gastroenterology referral, and it's called an upper endoscopy. It is done where the tube, the scope or the camera goes down the esophagus and then comes into the stomach. And then we look at the intestines. Normal intestine has nice villi, which is like, little, kind of think about a rug with the, kind of fibrous stuff sticking out. Whereas if you have celiac disease, it gets flattened. So when we take the biopsies, endoscopically, this looks flattened. Over here, you have nice villi that look like this. We can see scalloping or nodularity. And we take specimens and send it to the pathologist. Now, there's a specific classification for this, and we have, guidelines as to how we do the biopsies. If the diagnosis is celiac disease, then, we kind of confirm it with the biopsy. But in children, if, parents are sometimes resistant to having endoscopy or invasive tests in their kids, it's okay to not or to forego the duodenal biopsy if the tissue transglutaminase is more than 10 times the upper limit of normal, and if the child has a positive family history and their blood test shows a positive gene test. If there are skin lesions, such as dermatitis herpetiformis, it's a very itchy rash on the extensor surfaces of the elbows, knees, and the buttocks. The definitive diagnosis requires a biopsy, so they're seen by the dermatologist who do the skin biopsy, and this is what it looks like with the immunofluorescence. It's actually more common in men. Now, for treatment of this, patients get dapsone, but if they have the celiac disease, which is very commonly associated, then we do recommend gluten-free diet to these patients. There is a really wide differential diagnosis because, as I said earlier, you have a lot of systems that are involved. So, more common than celiac disease is irritable bowel syndrome, which is in 20 to 25% of the population, non-celiac gluten sensitivity, lactose or other carbohydrate intolerance, pancreatic insufficiency, especially patients that have chronic pancreatitis, either induced by alcohol, and then small bowel bacterial overgrowth or giardiasis, which is an infectious disease. Again, Whipple's disease, Helicobacter pylori, non-tropical, tropical sprue non-celiac disease, or viral enteropathy. And now even post-COVID, we're seeing a lot of patients that have symptoms similar to what one would see, with celiac disease. There's several medications that can make changes in the intestine that looks like flattening of the villi. And these would be non-steroidals, which are all the pain medicines, such as Advil, Aleve, ibuprofen, and then the hypertension medicines, such as olmesartan. And then patients that have had cancer and have undergone chemotherapy can have similar changes in their small bowel. Obviously, inflammatory bowel disease, which is a disease that affects the intestines, can also have changes and similar symptoms. Microscopic colitis, radiation injury, ischemic blood injury where there's low blood flow, eosinophilic gastroenteritis, another entity, IgA deficiency, which can be seen with common variable immunodeficiency, another one of the diseases that can mimic celiac disease, autoimmune enteropathy, and we know that intestinal lymphoma, which is the end point sometimes with celiac disease that's not treated, can also present with that. So what do we do for these patients? The most important thing is to have a gluten-free diet, okay? And that is the cornerstone of therapy because there are no medications. So a lifelong adherence to gluten-free diet is what we, recommend, for which we really also recommend getting a nutrition or dietitian to follow with us because these are very difficult. There is often inadvertent gluten consumption in lip balm, toothpaste, supplements over the counter. A lot of patients take vitamins because, you want to stay healthy, but at the same time, they may have gluten as a base. It's also present in beer and in other alcoholic beverages. So the most important thing is patient education and patient motivation. Absence of symptoms does not correlate to absent disease, and that's why it's really lifelong gluten-free diet. The benefits of doing this, if there's no celiac disease that's persisting, because people do respond, there are changes in the symptoms as well as in the small bowel biopsy. So you have decrease in risk of cancer, increased survival. There's definitely decreased healthcare cost overall, because if you don't have symptoms, you're not going to the doctor that frequently. It has been shown that patients do not get as many fractures. And then if you don't have symptoms, you have improved quality of life. I talked about mucosal healing in the intestine, as well as if you have aphthous ulcers. If you're absorbing all your vitamins, then there's correction of deficiencies. And patients do become negative for tissue transglutaminase. So we do check for that. And we talked about symptoms. Now, what are the challenges? There is a risk of contamination. So this is when you're going out to eat. I mean, a lot of people say that, the restaurants are gluten-free foods, but you don't know if that has been cooked in utensils where they cooked other foods. So overvigilance is necessary, but then sometimes it also leads to food-related anxieties. There is a lot of food that's available now, but it used to be that there weren't that many options, and the taste, people say that the taste is very good, but some people beg to differ. There can be cross-contamination, and like I said earlier, if you go to restaurants and you come across places that don't have gluten-free diet foods, you end up not going out as much in social isolation, which again is a double whammy in the COVID epidemic. And then you have to read the labels, and it has to be a lifelong change in your life eating habits. I just thought that this was very colorful, so I've created this slide which shows you all the possible gluten-free foods that you can have, all the numerous books that are out there that you can get for gluten-free diet, and international foods that you can get that are gluten-free. So these are examples of gluten-free diet. The consumer research from 2015 showed that there is $11.6 billion sale for gluten-free foods. Important to know is you avoid breads, pasta, processed foods, eat rice and corn, fresh fruits, vegetables, fish, meats. So anything that's not contaminated with gluten is okay. And then if you really are in a bind, there is a lot of there are a lot of resources that you can get, but I would suggest if the diagnosis is confirmed, then seeing a dietitian or a registered dietitian or a nutritionist is something that would be highly recommended. So the dietary recommendations are lifelong gluten-free diet, choosing natural foods over processed foods, avoiding lactose and dairy, because you have changes in the small bowel, and if you were not lactose intolerant, you tend to get, dairy products cause diarrhea and symptoms. There is a low amount of lactose in yogurt or kefir or fermented milk and older cheeses, so be careful. Choose foods that are rich in bioavailable iron, so it could be dark meat, poultry, or fish. Focus on what can be eaten over what is to be avoided, because otherwise it causes those food anxieties I was talking about. You want to get recommendations for vitamins and supplements. You want to counsel your family. So, again, it's controversial, but, testing first-degree relatives may be something that, the person wants to get done. If you're following up with a GI doctor, 6-month follow-up to check symptoms, retest serology if you have symptoms, because you could be inadvertently getting gluten somewhere, and then checking labs if initially they were abnormal. At the 1-year follow-up, you want to get your symptoms, serology tested, other labs done, bone densitometry if it wasn't done earlier. 2-year follow-up, you might get a repeat endoscopy with biopsies, but it's not a one and done. And if your primary care is following you and you're doing your annual physicals, then you do want to keep that annual physical going, even if you're in your 20s or even your 30s. And definitely if you're older, because come 45, you want to get your colon cancer tested, because having celiac disease does not get you immune to the other things that can happen as you age. So to kind of go over what we've talked about, there are gluten-related disorders. You have the celiac disease on the one end, and that is, where we must have a gluten-free diet. But there are other potential like adaptive changes with IBS overlap or non-gluten sensitivity, where you want to stay off the high gluten foods, but may not be essential, because it could be that you're sensitive to one form of allergies to something. And then IBS, where a gluten-free diet may be helpful, but then you want to make sure that you do get your other vitamins and minerals. There are no biomarkers for the non-celiac gluten-sensitive patients or the non-celiac wheat-sensitive patients, but the gene test is negative, and your IBS-like symptoms occur in minutes to days after eating this. and symptoms do improve on gluten-free diet. So it's okay to be on a low FODMAPs diet, which is what we recommend to a lot of our patients. It could be the sensitivity is due to fructan, wheat germ, gluten, which is the celiac disease, alpha amylase, trypsin inhibitors. 30% of the irritable bowel patient symptoms may opt for the gluten-free diet. So that's okay, but you just want to make sure that you do not forego your vitamins. So again, it is a spectrum. So the take-home points over here are that all that gluten grief may not be celiac disease. It may be gluten sensitivity, or it may be IBS. It may be just an adverse food reaction or food intolerance or a food phobia. So don't stop gluten till your diagnosis is confirmed. And you do want to see your doctor before you start stopping all gluten. Otherwise, you don't want to really go through a gluten challenge. But then if everything else comes back negative, then that might be the next step. If your diagnosis is celiac disease, lifelong adherence to gluten-free diet. There are concerns with travel and eating out, but again, in this current climate, it's easy to do because we're not traveling anywhere and we're eating out very little. You follow your dietitian's recommendations, so you avoid nutritional deficiencies, and you do schedule your follow-up with your primary care and your specialist as indicated. There are a lot of additional information that you can obtain from the National Institute of Digestive Disease, and this is in Spanish and English. And I have a slide which I hope Parminder will share with you. And there is a National Institutes of Health Medline Plus, where you can find more information, again in English and Spanish. And there's a National Institute of Health Celiac Disease Awareness Campaign, and you can find that on the other website as well. Additionally, there are patient-driven groups. There's a Celiac Disease Foundation and a gluten-free food recommendation from Celiac Disease Foundation. And again, they have their websites that a lot of patients have found very helpful. So I'd like to end with thanking you for zooming in and to let you know that there are International Celiac Awareness Day in May. There's a National Celiac Disease Awareness Day in September. This SCOE is for our British, brethren across the pond. There's a whole week in May that looks at celiac disease. And, again, it is a lot of different diseases included the GI disease. So you might be saying several other specialists other than the gastroenterologist. So if there are any questions in the chat room that came through, Parminder, I'm happy to take them.
Hi.
And again, thank you for your attention.
Yes, we do have some questions that came in. So I'm going to start with the first one. Is there any value to repeat positive endoscopy diagnosis for celiac after gluten-free diet for several years? Or should you continue to monitor bone health, osteopenia in older women, PMW, or elderly men with DEXA, vitamin D levels? What's your advice on that?
So looking at repeat biopsies, if the initial biopsy showed flattening or had changes, there's March 1, 2, and 3 based on the classification, then it's good to be aware that this has responded because inadvertent gluten ingestion does occur. And if they're IgA deficient, then their TTG will be negative initially and later on. So, you could do serologies if it was elevated and then came down, then you might repeat that serology at 1 year, at, 2 years. But if the initial biopsy was suggestive, then I would recommend getting follow-up with your gastroenterologist and getting that so you know that it's, the flattening is gone. It does respond.
Okay, great. Do you have any advice on intestinal cancer screening? Should it be more frequent in older adults with adult diagnosis after age 55?
So the diagnosis after age 55 may be a de novo diagnosis, meaning they may not have had any problems earlier on, or alternately, they could have had it. Now, if it's a long-standing celiac disease and they've had their endoscopy and it shows like say March 1 or 2, then I wouldn't be concerned about, intestinal cancer because it's very rare. And if the person's like sticking to their gluten-free diet and everything else is negative, I would not get overly concerned about the lymphoma or the cancer. Because, the one thing to remember for the small intestine, we don't have scopes long enough to go all the way. And what we do is called capsule endoscopy. And that's easy enough to do, but it's not really indicated unless there are symptoms. So the symptoms would be weight loss again, or ongoing symptoms, or if there's flattening of the villi. Does that answer the question?
I hope so.
Okay. I mean, people tend to get, remember, there is all these other anxieties that go along with it. So even if you have celiac disease or you don't, it's a chronic immune disease. The good thing about this disease is, like, unlike say, lupus, or like, rheumatoid arthritis, or, autoimmune thyroid disease, we don't know what the trigger factors are. For the celiac disease, we know it's gluten. So if we can control that, and in the future, they might come across medications that will actually digest that gluten before it gets to your intestinal wall, so that it doesn't need to be absorbed and create this whole, cascade of symptoms. So again, a lot of research going on in celiac disease.
Okay. I'm not sure what this is, but perhaps you do. NIMA, it says NIMA, used to make capsules with a gluten tester. Can you recommend any testing devices?
Over the counter, no, I don't. I think a lab test is a better test.
Okay. And if one currently has non-celiac gluten sensitivity, can you convert, or can that turn into celiac disease?
So unless you have a predisposed to it, right? So again, if you had the genetic test and you were positive for the genes, you could have, like a propensity to getting celiac disease. But if your gene test was negative, there's no way that you get that disease. So it's really important. Like if it's a negative gene test, then it's very unlikely. Now, some patients may get it, but then again, you'd have, either the diagnosis based upon symptoms and your biopsies. But the biopsies, again, could be from so many different things. So that's why, the doctors really like scratch their heads, at least I do, when you're trying to think about what else this could be. Very common to have IBS, very common to have wheat sensitivity due to whatever else is in that wheat. Like I said earlier, it could be, not the gluten itself, but could be the fructose in it, or could be something else in it that's causing it. And if you get better with avoiding it and your biopsies are negative, then I wouldn't really worry about it.
Okay, thank you. Can you expand on the nutritional deficiency you are concerned with by having a gluten-free diet?
So there's lots of things that you might be missing out on. And like I said earlier, you could be, if you're not eating a balanced diet and not seeing a nutritionist, you could get iron deficient, B12 deficient, folate deficient, you could get, minerals like zinc and copper, but I would not supplement anything unless the dietitian, suggests it. I wouldn't do anything for that. I would just make sure that you get good advice on a healthy, balanced diet that is gluten-free.
Okay. This person, her husband was diagnosed with celiac. She's joined him on a gluten-free diet because there's too much risk for cross-contamination. Is this gluten-free diet harmful for her?
Again, if it's not a balanced diet, and if the dietitian is the one that's, been recommending it, chances are that it's a complete diet. But if she's doing it, in harmony with her spouse, then, both of them need to be sure that they're not getting vitamin deficient, because you're both eating the same thing. Great.
Any clinical trials to desensitize gluten, like the peanut allergy type?
So again, this is not an allergy. It is an immune reaction. So that's the very important kind of take-home point, that celiac disease is not a food allergy. Peanut butter is a food allergy. Okay.
Are there, and so there are no clinical trials of any sort?
No, so you wouldn't desensitize to gluten, right? I mean, because it's an immune response in a genetically predisposed person to eating the gluten, that then sets off a cascade of changes within the intestine. And then because of the changes there, causes all the malabsorption, because, you have your lining that's absorbing now affected. So, it's like this whole cascade, and that's why you have extraintestinal symptoms as far as like, skin lesions, or people have bone disease or have anemia, inflammation.
So someone actually, I guess, just to what you just responded, someone just asked, but gluten sensitivity is not an immune response, correct?
Gluten sensitivity is not. It's like, when I showed that initial slide, that it was showing that there was like a metabolic disorder where you're not, you're just reacting to it.
Okay. And
Like
then
you do with lactose or something.
okay. How high is the risk of infertility and miscarriages with a positive celiac diagnosis? Is there any?
I don't have an actual number, but I mean, if it's a young person that's asking that, they should take that up with their gynecologist.
Okay. And then going back to what we were talking about, the gluten sensitivity. So can a person build tolerance to it?
So gluten tolerance to insensitivity, yes. That's why you kind of gradually eat something that's low. I mean, if you're eating like 5 slices of bread, cut back to 1 and see if that helps. It's something that you start doing and then gradually you get used to eating it.
Okay. And then I think I only see one more question here. Where would we go to get a genetic test to identify gluten in our family history? Is there something that exists?
No, there's a test that if you go see your primary care or your gastroenterologist, I mean, it's a blood test. I mean, again, it's in the patient that has the symptoms that's, been negative and you strongly suspect it. So it's not something that, you would go to, 23andMe kind of a
Yeah,
thing.
so it's not a genetic test, in other words. It's just regular, right?
Right.
Okay. Any other questions? I am not seeing any other questions to anything. So at this time, then, Dr. Chokhavatia, thank you so much for your informative presentation.